Welcome to the Oubliette of Survival, a comprehensive analysis of systemic, neurobiological, and psychosocial barriers to detoxification in co-occurring substance use and sex work. The refusal of detoxification for a woman in survival sex work is often seen as a failure of will. However, this report posits it is a rational, albeit maladaptive, response to overwhelming neurobiological, psychological, and socioeconomic threats. Our central thesis is that the subject is not avoiding withdrawal discomfort, but avoiding the dismantling of the only mechanisms that allow her to survive. The analysis covers neurobiology, trauma, socioeconomics, and systemic failures. Part 1 addresses the neurobiological imperative. The most formidable barrier is the altered neurophysiology of the brain under chronic substance use. Withdrawal is not merely flu-like symptoms, but a state of existential terror hijacking the survival instinct. Chronic substance use devastates the brain's reward circuitry through downregulation, reducing dopamine receptors. This creates a new physiological set point where the drug is needed just to feel normal, leading to severe dopamine deficits when the substance is removed. This deficit is experienced as the terrifying gray void, an emotional flatline where nothing provides pleasure. The fear of detox is the fear of emotional death, as this anhedonic state can persist for months and is a primary driver of relapse. This timeline shows that from acute detox through protracted abstinence, the neurobiological state causes a subjective experience of hopelessness and anhedonia, which reinforces the avoidance of treatment. Hyperkataphia is the hypersensitivity to emotional distress. Chronic use recruits stress systems, shifting behavior from using to get high to using to escape this emotional pain. Refusal to detox is a refusal to drown in this unbearable misery. Opioid-induced hyperalgesia, or OIH, is a paradoxical effect where chronic opioid use makes the patient far more sensitive to physical pain. For someone carrying trauma, this biological reality makes the prospect of infinite pain a rational fear. The presence of fentanyl introduces the terror of precipitated withdrawal. Since fentanyl is lipophilic and lingers, buprenorphine induction can instantly rip the drug off receptors, causing a violent onset of extreme physical and emotional distress. This leads to a deep fear of medical incompetence. Users fear that doctors don't understand fentanyl kinetics and will inadvertently cause them more harm than the addiction itself, creating mistrust of standard medical detox. Addiction involves temporal discounting, where immediate relief is valued far above uncertain future rewards. Withdrawal also dilates time perception, making a few days of suffering feel like an eternity, rendering appeals to short-term discomfort neurologically invalid. Part 2 focuses on the trauma identity complex. Drugs act as a chemical buffer against complex PTSD and emotional flooding. Detox removes this buffer, forcing confrontation with the full reality of past trauma, leading to a fear of drowning in suppressed memories. Dissociation is a crucial survival tool in sex work, allowing the individual to enter robot mode. Addiction greases the wheels of this psychological split. Detox means losing the ability to dissociate, making the trauma of the work unbearable. A rigid identity split often forms between the soft civilian self and the hardened worker self. Detox threatens to integrate these identities, terrifying her with the prospect of the true self being contaminated by the worker's memories. Trauma bonding links the individual to the chaos and the lifestyle, where the rush and the fix offer intermittent rewards. Detox feels like a betrayal of this bond and a severing of the only safety she knows, triggering abandonment trauma. Toxic shame leads to a spoiled identity, where she believes she is fundamentally bad and deserves her suffering. The outlaw narrative offers agency and status, which recovery threatens to strip away, leaving her with the fear of mediocrity. Part 3 covers the socioeconomic oubliette. Sex work provides golden handcuffs of immediate high cash flow, leading to financial dysmorphia. The trap is that to detox, she must stop earning, which immediately leads to financial collapse and ruin. The provider role, where she is the primary earner for dependents, offers purpose and counters shame. Detox is framed as selfishness and abandonment of those who rely on her, triggering immense guilt and resistance. The dirty money barrier involves legal paranoia and moral injury. Using illicitly gained cash for treatment reminds her of its source, leading to psychological resistance and a feeling that she must somehow clean the money first. Healthcare systems often exhibit hostility and judgment towards sex workers, creating the whore stigma. This fear of contempt and neglect, coupled with a lack of trauma-informed and safe spaces, creates a rational reluctance to seek help. Part 4 examines the existential void. The high-stress lifestyle creates an addiction to chaos. Normal life feels gray and painfully slow, and she fears she will never feel alive again without the adrenaline of the hustle. To the addict, the substance is a constant companion and a protector. Detox requires a profound grieving process, as she is being asked to abandon the one thing that consistently helped her survive. Early sobriety is marked by a void of time and activity, as the hustle consumed 24 hours a day. The true threat of the empty hours is that they are not empty, but full of surfacing trauma memories. Staying busy keeps the ghosts at bay. Part 5 explores pathways and interventions. Detox is currently framed as a loss of survival tools. The approach must shift from the paralyzing binary of using versus clean to harm reduction and stabilization. To overcome the fear of precipitated withdrawal, providers should utilize microinduction, like the Bernese method. This allows for stabilization on medication before fully stopping street drugs, avoiding the traumatic cliff edge of acute withdrawal. This table contrasts the traditional detox method, which requires painful full abstinence before medication, with the Bernese method, which safely microdoses medication while the person is still using, bypassing the terror of precipitated withdrawal. Addressing the economic void is critical. Recovery plans must include vocational rehab, financial planning, and reframing survival skills for legal work. She needs concrete solutions to prevent financial collapse and homelessness. Interventions should validate the survivor, not fight the bad girl identity. The narrative must shift. The drugs and work were armor, and the war is pausing. Therapy must help her separate her self-worth from her utility as a provider. Care must follow a trauma-informed sequence. First, establishing safety and stabilization. Second, chemical stabilization via medication-assisted treatment. Third, trauma therapy. And finally, vocational and identity work. In conclusion, the individual is trapped in a web where addiction and sex work provide survival. Detox is seen as a threat, not a cure. Intervention must focus on reducing suffering and lowering barriers, addressing biological, psychological, and economic fears to help her escape the oubliette. This video utilized a wide range of clinical and academic sources, as listed here in the works cited. These are some of the image sources used in the first part of this video. These are some of the image sources used in the second and third parts of this video. And these are the remaining image sources used to illustrate the concepts presented in this video.